What the objective of today is that we would like to discuss with you the possibilities for developing international evidence statements in physical therapy, knowing that there are many initiatives around about clinical guidelines and evidence-based statements, and we think it's about time that we should start an international collaborative. So the aim of today is to discuss these issues, so we only have a few short presentations, and hopefully quite soon after that we can go into a discussion with you. We'll do that by presenting each of us like a 5-minute presentation about what we will do, and then we'll start those discussions. So I first would like to introduce to you my co-presenters, and then we will start the different presentations. So first, Anne Moore is professor at the University of Brighton in the UK. Christopher Powers is associate professor at the University of Southern California, Los Angeles in the United States. Aimee Stewart is associate professor of the University of the Witwatersrand in Johannesburg, South Africa. And Rob Herbert, senior research fellow at the George Institute for Global Health in Sydney, Australia. And to introduce myself, my name is Philip van der Wees. I work as a program manager, quality and implementation for a collaborative between the Royal Dutch Society for Physical Therapy, Maastricht University, and Radboud University Nijmegen Medical Center here in the Netherlands. This initiative for developing international evidence statements has come a long way, as I said in my introduction. And that is because in the last 10 years or so, we have been developing guidelines and we have been discussing the possibilities for international collaboration. But until now, it did not happen. We did not really come to a real collaborative. So what we decided about a year ago, that we thought, well, if you look at the rapid growth of all this evidence in physical therapy, I'm not sure if you were at the session here this morning, that you could see from the PEDO database, for instance, that the increase of knowledge in physical therapy is really very, very exponentially over the last 10 to 20 years. That we see that many professional bodies are developing guidelines. For instance, the Chartered Society for Physical Therapy, the Royal Dutch Society for Physical Therapy, the American Physical Therapy Association, the Australian Physiotherapy Association, some of the Nordic countries. So many physiotherapy or professional bodies are developing guidelines, and we think it should be a real good opportunity for collaboration and see if we can do things together instead of duplicating and reinventing the wheel. So what we also see is that in the international field of guidelines, there is some collaboration over the last 10 years. The Guidelines International Network was established about 10 years ago, and in that Guidelines International Network, guideline developers are working together to see if they can help each other and if they can collaborate in guideline development. But still, in physical therapy, this initiative is limited. We have some ideas, we have some suggestions, but we never really made it into a real initiative. So what we thought, when we prepared for this session, we thought, well, the best way to do this is to write a paper about it. Because if you write a paper, then there's no way back. So then it's true. And I'm very happy, but also quite scared, I would say, because now it's really true, is that our paper was accepted 2 weeks ago by Physical Therapy, in which we describe our initiative for this international collaborative. So all the details of what we think that could be done is written in this paper, and it will be published in this fall. But that's where we start. So for us now, and we as presenters, we looked each other in the eye yesterday and this morning, say, is this what we really want, and is this what we really want to pursue? And we thought, yes, this is what we want. But now we'd like to check that with you and what your ideas are about international collaboration in evidence statements in physical therapy. So much for my introduction. And I would like now to ask Anne Moore to start with her first presentation on what evidence statements are.
Good morning, everybody. Lovely to see you here, and it's really nice to see so many of you here. I guess if we'd been doing this 30 years ago, there'd have been 5 of us here, and we'd have been the speakers. So it's quite nice that we've moved on, really, substantially. What I'm going to do is to talk about terminology in this first session so that we all understand where we're coming from. And I'm going to start by talking about clinical practice guidelines. And as we understand these are systematically developed statements which are designed to help practitioners and patients make decisions about appropriate healthcare for specific circumstances. And there are a number of potential benefits of guidelines, and I say potential because it does vary across the world in terms of the calibre of the guidelines that are produced. And we have to ensure that the calibre of any guidelines that we do produce are absolutely right for the audience. But the potential benefits are to improve clinical outcomes, to reduce the variability in clinical practice, which actually sometimes makes our consumers and the people who pay for our services quite confused. Increase the use of known effective interventions, which can actually sometimes save quite a lot of money for departments, and of course which will produce greater cost effectiveness. We also feel that we can increase the transparency of evidence to justify interventions, and we can legitimise the profession in the eyes of external stakeholders, including commissioners who are paying for our services. So those are the potential major benefits for us. I want to talk a little bit about two types of terminology that you'll see and you'll hear and you'll read about in various papers. And one of these is an evidence note. And we do a lot of work around this at the Charter Society of Physiotherapy, and I'm very happy to say that the programme leader for the SKIP project is actually in the audience here, and I hope that Ralph Hammond, do you want to wave, Ralph? Will actually kind of put into the discussion quite substantially. He's the programme leader for the SKIP initiative, and the SKIP symbol stands for Supporting Knowledge in Physiotherapy Practice. So an evidence note, as we would call it, is a summary of secondary and or primary studies related to a specific client group or a disease. And the way in which these are constructed is to identify a gap in the evidence base, use a standardised critical appraisal tool to actually look at the level of evidence that's available and provide pointers for clinical practice. These notes are then ratified by independent review, which we do within the organisation, the Charter Society of Physiotherapy in the UK, using an appraisal tool, so for example the AGREE instrument. Evidence statements, as we've talked about in the paper that Philip has described, consist of a literature review with a specified search strategy, and these will normally include high quality guidelines, but could include systematic reviews and or new papers that have just arrived. And they will focus on specific questions. They will also identify evidence for specific circumstances and for specific client groups. And we hope that also these could be highly culturally sensitive. And these statements will relate to risk factors, diagnostic testing, prognosis, and also interventions. The results of the literature review and the assessment are summarised into an evidence table to present the results, which is called the synthesis of evidence, and these are graded in terms of quality against a set of methodological criteria. And of course we would use the usual hierarchy of evidence. And the synthesis then leads to evidence statements which we hope will be usefully incorporated into practice across the international domain. There are a number of potential benefits for professional bodies of these evidence statements. First of all, it can give international support for practice and build capacity within our WCPT family for evidence-based practice. Secondly, we can provide evidence to challenge prescriptive pronouncements from national health services and funders, which I'm sure you've all met from time to time over the last few years. And it provides a cost-effective means of producing member-focused support materials, which a lot of our members are crying out for. It could also prevent the overlap of guideline development, and we've seen a number of these things throughout the world. You know, a number of low back pain guidelines have been developed, not all of the same standard, and some are more recent than others. But actually, if we focused on just having one guideline or one evidence statement for the whole world, then it would actually be quite helpful. This may not be totally possible, but it's something that we should be perhaps working towards. And we can yield country-specific clinical advice, I think, from electronic international collaboration. And there's a few references for you, but you'll find a lot more references in the paper that we've produced. So that's my general introduction, talking about terminology, and Philip is going to pick up much more on the evidence statements later on. Thank you very much.
Thank you, Anne. So Anne talked about the identification of existing guidelines to come to evidence statements, and now Rob Herbert will follow up on that and to help us on how to identify these evidence statements using existing databases.
Thank you, Philip, and thank you for the opportunity to participate in this symposium. My brief is to talk to you a little bit about what's out there in terms of evidence statements or clinical practice guidelines. The easy way to find clinical practice guidelines is to go to one of the databases, and there are many. The largest, Philip was informing me before this session, the largest is the GIN International Guideline Library. And another very large database is the Agency for Healthcare Research Quality National Guidelines Clearinghouse. These databases index thousands of clinical practice guidelines, but at the top of the list I've put PEDRO because PEDRO is specifically a database of clinical practice guidelines in physiotherapy. For those of you who are not familiar with PEDRO, you can use it to search for clinical practice guidelines. If you go to the advanced search page in PEDRO, enter your search terms, low back pain or incontinence or shoulder pain or whatever it is that you're interested in. Indicate that you're interested in practice guidelines and run your search. You'll find what you're after. So PEDRO is designed to help clinicians find clinical practice guidelines relevant to their own area of practice, but it also provides a useful library of all clinical practice guidelines, or at least all that we've been able to find relevant to physiotherapy. What's out there? Well, we've been able to identify 985 clinical practice guidelines relevant to physiotherapy. There are many more than that, but we specifically focus on evidence-based clinical practice guidelines. Those, for example, which include a systematic review of the evidence. You might be interested to know, I was surprised to know, that the largest proportion of those practice guidelines is in cardiopulmonary physiotherapy. About a third of all of the practice guidelines we've identified are in that field. Another quarter are in musculoskeletal physiotherapy, and the rest is spread out fairly evenly across most of the remaining disciplines. Overwhelmingly, the guidelines, at least the ones that we've been able to find, are guidelines published in English. The next largest language is French, and again there's a number of other languages in which these guidelines have been published. This possibly overrepresents the amount of English guidelines because when they're published in languages other than English and English in PEDRO, they're categorised as being in English. One observation that I want to make that is relevant to the rest of the discussion is that there appears to have been, at least in some areas of physiotherapy, quite a high degree of replication of guidelines. So, for example, if you search for acute back pain guidelines published since 2007, there are 9 sets of guidelines in this field. And you can see that they're published by a number of organisations and institutes from a number of different countries. Likewise, if you look for stroke guidelines that have been published since 2007, there's 6 of those, again, published from a number of different countries. So, in summary, it's easy to find clinical practice guidelines relevant to physiotherapy practice. There's lots of them, but there appears to be quite a high degree of replication. Thank you.
Thank you, Rob, for presenting those databases. The next presentation is by Chris Powers about an example how the American Physical Therapy Association is developing guidelines or evidence statements, and to see what we can learn from that in our international initiative. So, Chris, the floor is yours.
Good morning. So, I think, at least in the United States, evidence-based guidelines are critical to the profession of physical therapy. We have a finite resource for healthcare dollars, and public policy is demanding guidelines for spending of our healthcare dollars. The goal is efficient, effective treatment for our patients, and in order to get the biggest bang for our healthcare dollar. And as a profession, I think we can use guidelines to be more proactive rather than reactive. If we publish evidence-based guidelines as a profession, it is more likely that policymakers will adopt these guidelines for physical therapy as opposed to developing their own guidelines. In other words, we have to take control of what we are doing in our own profession. And if we don't develop our guidelines first, other people will do it for us. And we're in the best position to guide our own practice. We had experience with this directly in California in 2004. The Workers' Compensation Board of California legislated guidelines for low back pain. These were done without consultation of physical therapists. And because of that, physical therapists were largely left out of these guidelines. And what physical therapy was in these guidelines was not current with respect to our current practice. In 2004, we did not have good guidelines for low back pain to drive our practice. So it's important, clinical guidelines to policymakers. The benefits to follow evidence-based guidelines basically direct how healthcare dollars are spent, especially in the United States. Avoid pain for treatment that is unnecessary, costly, or not effective. And we have a big problem in that we have a lack of consistency of treatment across various clinical settings. So the importance of clinical guidelines to physical therapists. This provides a quick access to synthesis of evidence. It gives the physical therapist direct access to the knowledge base of the experts. Allows one to self-assess their own current practice. And assists with developing direction for clinical research. Now, the orthopedic section of the APTA began developing evidence-based guidelines in 2006. The primary benefits were deemed to be describe best practice for common musculoskeletal disorders for both physical therapists and non-PT stakeholders. The goal was to place the PT guidelines on the guidelines.gov website and hopefully provide common terminology and measures for National Outcomes Database. Now, the guidelines to date are as follows. The following guidelines have been published. So we first started off with heel pain, plantar fasciitis in 2008, followed by neck pain, and hip pain and mobility deficits in 2009, knee stability and movement coordination impairments in 2010, and Achilles pain, stiffness, and muscle power deficits in 2010 as well. And lastly, low back pain in 2011. There is a big plan to develop many more clinical guidelines as we move forward. These guidelines are established largely by content experts, researchers, as well as clinicians, and reviewed by another independent panel of experts, researchers, and clinicians. So these guidelines are being published in JOSPT, Journal of Orthopedic and Sports Physical Therapy, which is an open access journal, as well as the orthopedic section of the American Physical Therapy Association. And if you go on to the orthopedic section website, you can provide feedback to any of the guidelines that have been published. Thank you very much.
Okay, thank you, Chris. We now know that there are guidelines around and there's evidence around, but we also know that the application of the applicability of guidelines or evidence may differ around the world depending on the local, the national situation. And Aimee Stewart is now going to present us examples of what the applicability of evidence is in lower and middle income countries.
I'm going to take a slightly different tack this morning and present something that is slightly different, but nonetheless very important. I certainly think that WCPT is to be lauded for attempting to try and get some international parity across guideline development and using the best available, obviously, good clinical evidence. However, for internationally acceptable clinical guidelines to be relevant, room must be made for those that don't fit into the developed world model. And the developing world has unique challenges and that need to be considered and to become part of All right, the development of clinical guidelines in the developing world has been slow. We've had a number of challenges, and these have mostly been related to costs, the costs of guideline development, the lack of specific expertise in order to do that, and time constraints because of the incredible amount of work that everyone has to do. In some instances, the guidelines may be appropriate. These guidelines that we've heard about this morning, they may be appropriate, particularly for patients who are managed in private facilities, but they don't necessarily work for the majority of our patients who access public. First of all, the public medical facilities, particularly in sub-Saharan Africa, are overburdened with the HIV/AIDS pandemic. And this has resulted in extraordinary pressure on beds. There's a shortage of beds, and this means that there's a very, very quick turnover of patients. And in some of our hospitals, patients who've had a stroke may in actual fact be discharged as soon as their medical condition has stabilized, and they're discharged home to an unprepared family. The staff are overstretched, they're often junior, and they don't have sufficient time to really get involved in appropriate rehabilitation. And in addition to that, we have very limited step-down and rehabilitation facilities within the public sectors in developing countries. In addition, our patients have huge socio-economic problems. They very often are unemployed either prior to a disabling event and certainly very often after a disabling event. This means that their ability to access any form of rehabilitation is really limited because they simply, in many instances, can't afford the transport to get to where the rehabilitation is available. This has resulted in high levels of caregiver strain, and because the caregivers, particularly in Africa, are usually members of the family. And so they're unprepared for the person. They may have to have given up whatever income they had in order to care for the person with a disability. And so it results in a really problematic situation. The physiotherapy challenges are we need to look very carefully and start developing interventions. The physiotherapy challenges are we need to look very carefully and start developing interventions that are suitable for our particular scenario. And we really have to do that more and more so that we can take what is existing, look at the challenges that we have, and start developing appropriate interventions, taking these challenges into consideration. In addition to that, we have another problem, and that is that we can't necessarily take outcome measures from the literature, from the international literature, and outcome measures that have been developed in a developed world scenario, and think that we can use them on our patients. So we've also had to go through, and we are in the process of going through, a very interesting educational scenario of developing our own outcome measures. And we've done that fairly successfully. So we now have a few, and we have a few ongoing projects in order to make sure that we are measuring what we need to measure in order to be appropriate for the particular socio-economic level of our patients and the particular cultural entities with which we work. In conclusion then, we have the potential to feed the most interesting and exciting research into the international grid. Our work is exceptionally challenging, exceptionally exciting, and in no ways is it second best. The developing world has the greater part of the world's population. Therefore, we have the greater part of the world's people with disabilities, and therefore we have the greatest rehabilitation challenges. And we need to find our own unique way of solving these issues and then feeding this information into this wonderful international evidence base. Thank you very much. Thank you.
All right. Now, the proof of the pudding is eating it, they say. So the conclusion, where we are right now, is that we know that we have evidence, a rapid growth of evidence base for physical therapy practice. We know that there are many organizations developing guidelines, and we can find those guidelines. So we know that we have an evidence base for our practice. What we also know is that the applicability of this evidence may be different depending on the situation of your country, the healthcare system you're in, the resources you have. So the translation of this evidence into a recommendation for daily practice may be different from one country to another. That's the situation we're at. Now, where does that bring us in international collaboration? We've tried to develop a model, and that model roughly says that if we are able to develop evidence statements at a universal level, allowing for some discussion of applicability of this evidence in different healthcare systems, using resources, having different types of patients, then countries or local institutions might use these evidence statements to translate this into a recommendation really tailored to their specific situation. And that's the basic rationale for our model. And the way we're trying to do is that hopefully, depending on the success of this meeting today, is that we would consider this meeting as a launch of our international collaborative. So this would be the start, seeing if we have enough power, enough energy, enough support for our initiative, and I hope that we will be able to discuss that. And then we would like to install a steering group. We, as presenters and authors of the guideline of the paper, would be very happy to initiate this as an initial steering group, but we'd also like to invite you to participate in that initiative if you're willing and able to. Then the next step would be to develop a standard for evidence statements. What kind of process would we run and what kind of methodology would we use? And we think that should be fairly, easy is too easy, but it should be feasible because there are many guideline methodology programs available, and we can use them to see what is the basic principles we can use from those programs for our evidence statements. And then the next step, and that's a tricky one, of course, funding. How can we find funding for projects? And probably later in the discussion today is that we can probably find funding in different ways, but it is certainly an issue we will have to talk about. And if we have funding, we could go and develop our first evidence statement. So that's basically the idea we're having. Now, how would we run projects? What we think is that we would start, there are two ways actually. You could either start by identifying existing guidelines and evidence statements around the world and see if you can derive evidence statements from those existing guidelines. So look at what's around in evidence. Don't do the whole process for a full guideline development, but use existing guidelines to see if you come up to a joint common conclusion, and that would be the evidence statement, which could be used by other countries to go back again into a guideline at a tailored national or local situation. Another approach would be that if a certain organization, APTA, KNGF, CSP, some of the other countries, would develop a guideline, that we would add an international perspective to that development to see if you can do a sort of surplus on top of that project for international development of evidence statements. And I think we have I don't dare to say successful example yet, but we have an example yet, which is the Parkinson guideline, which is being developed at a European level. And the project leader of that project, Samira Keus, is in the room today. Could you stand up, Samira, please? So she'll be able to help us out with the things, the pitfalls and the benefits of doing that project at a European level. So we have examples of how that can be done. So those are the two approaches we have in mind. And we think that we should also include the world of practitioners in physical therapy around the members of WCPT to see what their questions are and what their priorities are. So that would mean that we identify the needs for evidence statements, so we have support for developing those needs. And once we've done that, we think you could use a relatively small project group of 4 to 6 developers, having a reference group of 10 to 15 clinicians, and perhaps also patients involved if possible. And that should be the outline of trying to get such an evidence statement developed. And we also think, because time investment of researchers is being asked here, that we should aim for a publication of these statements into a peer-reviewed journal. That would also help to get time allocated by researchers, because that's what their job is, to try to get papers published. So this is what we have in mind for running projects. And basically the result of such a project would be a format, which we have an example of such a format, of what an evidence statement would look like. We think of concise documents, 2, 3, 4 pages, so very, very brief, very short, with an introduction about the topic and what the issues are around that topic, briefly describe the method of developing the statement, then present the identified literature in evidence tables, and finally, and that's the actual evidence statement itself, to come to a conclusion. What is your scientific conclusion based on the question you've asked before you started the project? And then a session or a section for considered judgment, showing that this evidence may be applicable or not applicable depending on different situations in your healthcare system or given the resources that you have in your country. So we may provide some of these considerations that can be used by countries for developing their actual recommendations for their local purposes. So this would sort of summarize that process, and we would think that a very basic, simplified approach of finding the evidence, weighing the quality of the evidence, coming to a conclusion, then have that considered judgment what the applicability and what the impact for patients is, what kind of preferences patients have. So many of these issues may come around, and that would then result or be the basis for the translation into a recommendation for daily practice. So this is the basic model of developing such a statement. And now the big question is, do we have a business case? Is this something really feasible, or are we just sort of fantasizing here, and is this something which would be very difficult to pursue? So that's the basic question also for you today. And actually I would like to spend the next half hour to discuss these issues with you and to invite you to help us to see whether this was or is feasible and how we could set the next steps in doing this. And so I formulated 4 questions. What are the barriers, or what are the facilitators for starting such an international collaborative? What do you think of that? Do you think it's feasible to set up projects and to create some funding for that at international, national level? Would you like to join us? Would you like to participate either in the steering group or in development groups or in reference groups or in any other way to help us out in getting this started? And how should we proceed? What would be the next step? So I don't think we should address these questions in a specific order, but I would just like to start with a first invitation for comments, suggestions. What do you think of this? So who is going to be that first person?
David Beard, Oxford. First of all, as a scientist, I'd like to support this fully, and I think it's a very laudable concept. As a physiotherapist, I'm slightly more nervous. And I'm nervous because I want to have some evidence, if you like, that the timing is right for this. Are you sure that we've got sufficient evidence in practice to be able to go this far? And I'm worried because it has the potential to undermine practice, although it's a good concept, if the evidence isn't there. And I use the example in surgery. It's no accident that surgical procedure, for instance, like replacement of the knee, still has no clinical guidelines at a surgical level. So I'd just like to ask the panel if they're really sure that the evidence exists for this. I don't want to quash it at all, but I want us to think through it to make sure that the timing is right to do this, so we don't set up something with sand underneath it.
Okay, thank you. The process for the discussion would be, I think as you suggested, you say, well, you support the idea, but is there enough evidence, and what would that, the impact of that not being evidence for such a topic, for instance, be for daily practice? And I would like to invite my co-authors to comment on that. But I would also like to proceed further so we can see how the process interacts, and then we'll see how this goes. And maybe we can pick up a few items later and see if we can identify some of the further topics to be clarified over after this session. So thank you for that. So anybody from my panel? Rob?
Thanks, David. Fair comment. In response, I'd say, well, we now have over 16,000 randomised controlled trials, and of course many other sorts of evidence to support physiotherapy practice. Sooner or later we have to bite the bullet. I acknowledge your concern that we still don't have good evidence about precisely how to administer all treatments for all problems. That problem is going to be there forever. But of course clinical practice guidelines are not purely statements about high quality research evidence. They incorporate expert judgment by clinicians. The important thing is that they make explicit where recommendations are based on high quality evidence and where they're based on the experience of good clinicians.
Thank you. I don't have a full light, but I think I see somebody there.
Yes, Julie Tilson from the United States. I think this is very exciting. I compliment you on all the work that you've done and look forward to the paper. It's certainly willing to help. My comment is you had that nice kind of layout of your process on a couple slides back. And I think that we need to think about beyond the recommendation, the publication in the paper. We know, and I'm sure the panel knows, that we have evidence that it's very difficult to take it from publication into practice. And I hope that as groups put their effort together to come up with a statement, it also comes with educational tools, mechanisms to actually take it from the piece of paper into practice. And that would then be modifiable. Educational resources for clinicians would be modifiable by different localities for different needs.
Thank you very much. So your suggestion would be to use or not to forget the implementation when you start doing this. So you have to see if you can really get them into practice.
Yeah, as hard as it is to get it into publication, it's so far from being finished when you get to that stage. And I'd love to see the early process involve that on the ground, in the clinic, educational piece that clinicians could get through the web probably would be the most useful.
Thank you. In the back? Yep.
I think it's a great idea as well, but I would also, my name is Helen French from Ireland. My suggestion or comment for the panel would be when we use scoring systems, we traditionally look at the quality of the methods, but in complex interventions in physiotherapy, we perhaps don't appraise the content of the intervention sufficiently. And I wonder, could this be a focus of these type of evidence statements rather than just focusing on the methodologies used?
Okay, thank you. Anybody would like to comment on that?
I'd like to agree with that. I mean, I think there are other issues. It's not just about the intervention you're talking about, but it's actually about the skills of the people who are applying the intervention. We have to be critical of trials which actually don't really spend a lot of time looking at that, which, from my perspective, I would think that would actually reduce the number of randomised controlled trials that are actually available for us to develop these guidelines. But I think in many ways that is what made guidelines less acceptable to a number of individuals across the world, because they haven't seen the relevance. And I think this group will need to take that firmly on board.
Thank you.
Thank you. This microphone here, and then here up to the front.
Andrew Hirschhorn from Sydney, Australia. I'm part of the Clinical Developers Network in Australia, which is run through the National Health Medical Research Council. And obviously to develop one of these guidelines, it's either a massive labour of love or it takes considerable funding. Now, to get that funding from the research councils, presumably the development of our physiotherapy guidelines will need to fall under the methodology that they use. You've obviously got an idea about how you think that the development of the guidelines is going to go and be presented. But in different parts of the world, to get the funding to do it, presumably will need to fall under the local research council's guidelines.
Yes, your basic concern is then how to find that funding, knowing that it is resource intense to develop these guidelines.
Yeah, that too, but also to, I guess, get a guideline acceptable in the Australian situation. Then presumably we need to fall under the Australian National Health Medical Research Council guidelines, which may be different from, the European Research Council guidelines or the United States Research Council guidelines. So I think that there are going to be other obstacles to us just, setting up an international collaboration. We've got to work in systems which are different within different countries and locales.
Okay. Anybody would like to comment on that? Rob is hesitating. Yeah.
I could respond very briefly to that by saying, Andrew, that we had exactly the same discussion yesterday evening when we were talking about this. One of the things that would probably be a useful exercise early in the process would be to do a bit of a survey of the requirements of different regulatory agencies for the production of clinical practice guidelines. I'm sure there's a common set of requirements. It might not be possible to satisfy every country's requirements, but we could possibly go close to it.
All right. Okay, thank you. You're the next one.
Yes, Anna Jones, Northumbria University, the UK. I'm thinking about how to attract funding to this initiative, and I'm wondering if we're missing the importance of educators in relation to their use of guidelines, and whether perhaps this group could consider having a think about how they link their work not only to clinical practice but to the teaching of physiotherapy. Perhaps even getting students involved in some of the work that's being done.
Okay, thank you. I think that's an excellent suggestion.
I think it's a great suggestion. I think none of us use our student cohorts to best effect, actually. If you think about the UK alone, we'd have, 2,000 students a year doing dissertations. We could actually gather an enormous momentum using students in an appropriate way.
Yeah, I think it would give them a real appetite for the evidence, actually, to be part of an international collaboration, creating the evidence with which they're going to practice in the future.
Okay, thank you. Thank you very much. Way in the back.
Claude Maroun from Lebanon. This is a very interesting project, and it is very important for countries where they cannot develop their local guidelines. But I would like to give you some insight from our experience in implementing clinical guidelines in our country. We adopted international guidelines, and we were afraid about the applicability, how much the culture would be a barrier for the implementation of guidelines coming from a different country. And we found out that we have common barriers, but that we can find internationally, and others that were specific to our culture. So it's very important when you start developing these guidelines, try to include, let's say, a more global insight from different countries and from different cultures in order to have them applicable. Thank you.
Thank you. Thank you very much. I'd like to go to this microphone, then that one, and then front, and then back to the back. So, sorry about the delay, but we'll get there.
Hi, Neil O'Connell, Bruno University in London. I would like to ask the panel, how do you feel the wisdom of including lower levels of evidence in these guidelines? If we're presenting and publishing these guidelines outward to the world, and we start including things as potentially biased and infected with vested interests as clinical experience can be perceived to be by other people, could it be that our guidelines would look more like an expensive advert than actually a rigorous and robust clinical guideline, which perhaps it would look more like if we restricted it more to RCT and review level data?
Yeah. So you say what to do with those areas where there's not a lot of evidence around?
I would suggest that including clinical experience from a professional-led guideline might actually be something that detracts from the legitimacy of the guideline.
Okay, thank you. I think, is anyone willing to respond? I could also, because I think this would sort of look a bit perhaps like the evidence notes project. Is that true, Ralph? Is it something you could perhaps comment and help us with? Sorry that I'm introducing a new person behind the microphone.
Hi. Yes, we called it, it's Ralph Hammond from the Chartered Society of Physiotherapy in the UK. We called our programme SKIP, Supporting Knowledge in Physiotherapy Practice, because we've been trying to recognise that knowledge comes in more forms than just an RCT or evidence of effectiveness of interventions. And I think our plan with an evidence note was to say that sometimes there isn't enough robust RCT-type evidence to make a strong statement or a recommendation for clinical practice, but there might be something we can say on the basis of a systematic review in collating knowledge to put it out there for people to digest, and that's probably better than nothing. An evidence-based practice is supposed to be making use of the best available evidence. So I think what we're trying to do is to be broader than one single model.
Okay, thank you. But it's certainly an issue we have to consider what to do with it. Thank you. Over there.
Hi, I'm Joëlle from France, working at the Guidelines Department at the French National Authority for Health. And I was wondering, this project is for doing guidelines for PT. But one of the good quality criteria for guidelines is that it's done by multi-professional elaboration and not just PT elaboration. So how can we, with patient tools, to have the patient preference not just from papers, but real patient working together with professional? So how do you imagine to work with other professionals in a WCPT project.
Okay, so your question is how to integrate the multidisciplinary perspective into the guideline development.
Sure.
Yeah. Anybody suggestions? Anybody from the room? Samira has a suggestion.
My name is Samira Keus. I'm the project leader of the development of the Parkinson guideline, the European guideline. And indeed, in our project, we have decided, based on all the information we've gathered from the Guidelines International Network, that it's very important to have the patients included in the guideline development, and not as we used to do at the end of when the guideline is nearly finished, but from the start. So when you look at the questions that are in practice, it's from the patients and the therapists. And so we decided in our group to have also in the writing group to have patients included. As for the physiotherapists, it cannot be any patients, because the patient need to be able to discuss on the same level with all the people in the writing group. But we've been able to find people, and we've now had our first meeting with the writing group, and I think it's going to be very successful, because people from their background, whether they're mainly from research or from clinical practice, hands-on, or whether they're a patient, they give different color to the guideline, and I think it's very important that should be included in the model as well.
Okay, thank you. That might be a good way to do it. Yes, please.
Yes, my name is Mariela Graciano. I work in Luxembourg. I am also the president of the Association of Physiotherapists in Parkinson's Disease Europe. From the experience we have in Europe, the broad difference of different countries, the different levels of working, to move to an international guideline, and from looking at that and what we had in the previous session, countries like South America, only Brazil is contacting really Pedro. You got Africa and you got the Asian community. So if we are going to go into international guidelines, we really need to go bottom up from the beginning. And one point would be to contact also the patient associations in those countries far away, because the patient associations are going to be stronger perhaps than the physiotherapy association. That was just, don't forget, international is big, and we don't want to have a double, the well-developed and the underdeveloped countries.
Thank you. And your suggestion is make sure that you do a bottom-up approach in getting support for your initiative. Yeah, thank you. I'd like to go to that microphone. Yeah.
Hi, I'm Jennifer Jasper from the University of Cape Town in South Africa. And I think my concern about the guidelines, I think obviously we do need evidence, and we just have to see how useful Cochrane and Pedro have been. But I think I'm worried about the unintended consequences of having guidelines, because it takes a long time to develop, and there have to be moving targets, and what is advised today is not going to be the same in 3 or 4 years' time. And once it is a guideline, it becomes a document that, in our situation, medical aid societies, the Health Professions Council, they could hold you up to, that's what you have to do because it's in the guidelines. But there can be a whole lot of innovative practice that is not in the guidelines, that I'm at a university, that we would then it would be useless for us to teach, because it's not actually in the guidelines, nobody will recognize it. So the guidelines will always be one step behind, if not 2 or 3 steps behind practice. So that's the one concern that I have, that we limit ourselves through it. And the second concern is, I think, the importance of efficacy and effectiveness, which I think Aimee was talking about, that because the guidelines are international, because something works, doesn't mean to say it will work in our situation. So that you need double guidelines in this particular situation. And then the third thing that I want to talk about is not just the efficacy and the effectiveness, but the cost effectiveness. So that what is an ideal guideline for an unresource constrained country would not be the guideline for a country where it is resource constrained. So those are the 3 major concerns that I have about the idea of guidelines. Thank you.
Okay, thank you. Would anyone like to address any of these 3 issues about Aimee? Yeah.
Hi, I think that Jenny has raised some very important issues. And certainly one of my fears, if you look at funders in my country, for example, they will actually latch onto the guidelines as this is how the treatment must be, or this is how the management must be. So I think that we do need to be very careful, and I think that the guideline probably needs to be broad enough, and we must be very careful that it's not a sort of a point-by-point, this is how you have to manage a particular patient in a particular situation. And it has to be broad enough to ensure that we see all the different patients in different circumstances. So I think that as we move forward, and I think there's a lot of enthusiasm to do so, we need to, as in every step that you take in life, you need to look very, very carefully at the unintended consequences. And I think that Jenny has raised an exceptionally good point. Thank you.
Thank you. Chris?
Yeah, those are excellent points. I think we have to be very careful about how we start and maybe really select the first couple guidelines to be really key areas that we feel comfortable with the evidence and that we feel like would have good translation across multiple countries in different areas. I think that's really going to be a critical first step to make sure that we pick some really good topics to start with. I think once we put a guideline out there, I agree that they are moving targets and they're going to have to be continually monitored and updated on a regular basis. These are not static documents and they're going to change very, very quickly. So, I mean, we also, from a resource standpoint, once we develop a guideline, we have to maintain a guideline. We have to make sure that it's current based on the best available practice and evidence.
Rob?
So just one very brief comment, and that is that innovation historically has been our friend but also our enemy. Too much innovation is a dangerous thing. We need to strike the right balance between being innovative and being rigorous.
Thank you. I would like to go to the microphone in the back and then go back forth and then back to you again.
Thank you. Leslie Dawson, the UK. I was delighted to hear Aimee's presentation about issues related to the so-called developing world. And bearing in mind that the panel represents mostly the one-third world and Aimee represents the two-thirds world, I'd be interested to know how the panel think the issues that she raised can be integrated into development of international guidelines.
All right, challenging question. Who is taking that one? Anne? Yeah.
Yeah. Hello, Leslie. I think we need to look seriously at our steering group if we do go along this route, and we need to ensure that we've got proportionality in that particular steering group. I think that's very important. But I also think it's useful for us to use the infrastructures within those countries to actually support this development, and it may mean that some individuals could actually play a large part in gaining information, for example, from patient associations and from clinicians' associations in order to focus us in the right direction.
Okay, thank you. In the back.
Trudy Revick from Australia. As you know, I guess I've been involved in the development of 2 multidisciplinary guidelines for our national organisation, NHNMRC. So just coming from that perspective, the 2 issues I'd bring to this would be, firstly, in doing that, in the development of a guideline takes time, as you know, and in that situation, just in a national perspective, it took 3 to 4 years. So the issue of currency is important because by the time you get it out, it's already late, and how do you keep them current? The second point I just wanted to bring up in terms of implementation, I guess my favourite area of research. We don't yet have sufficient evidence, that's, I guess, strategically the goal, what is it? Because we don't yet have sufficient evidence that if we implement this, we adequately change health outcomes. And ultimately, that is the goal of producing guidelines. Yes, we want to change health practice, but ultimately, hopefully, we want to change the outcomes of the patients we treat. And as you know, the implementation studies that have been done to date, at least in musculoskeletal physio, have not shown changes in health outcomes. So my big concern would be, we'd want to make sure you don't put so much money and resources into something that ultimately may not change health outcomes.
Okay, thank you. So that's both about selecting the topics, and it's also about make sure that you keep a simple process, which doesn't take too much time, otherwise it will be outdated by the time you finish your project. So thank you for that.
Yeah, and I guess it's just that comment about what the overall strategic goal is for that, because I think it's important if you're going to invest that amount of time and money into it. Yeah. Is it that we want to change health outcomes? What is it that we're wanting to do?
Okay, thank you. Any suggestions on those health outcomes? Anne?
I mean, I think outcomes are a big issue for us generally. You know, a lot of the outcomes that we do utilise are not really that sensitive for our needs. And we still need to develop more outcomes. But one of the other things that we're not utilising enough is the patient's voice. And so for me, you know, the qualitative analysis of the outcomes of treatment are actually much more important than having a numeric outcome measure. I would rather hear from patients, and people will say, well, those findings are not generalisable, but often they are transferable. And I think we need to think about that. We also need to think about it quite seriously in our guideline development. But I'm not coming from a very positivistic background, or I did, but I've moved on.
Thank you.
Just to challenge everybody.
Thank you very much. I'd like to go to this microphone.
Okay, my name is Bernhard Borghetto. I'm from Germany and lecturing in a master's program for physiotherapists, but I have to admit I'm a sociologist. But anyway, I appreciate very much the initiative and the discussion here. And I think it's, especially for Germany, very important for the process of professionalization. You know, we have some transformations in the moment, and this would be very important to process. I want to address a methodological remark to the point of effectiveness of therapies in institutions and different countries. Some points I wanted to make just came up in the last remarks, but I want to put it a bit further. We are challenging in the moment the hierarchy of evidence, and we are working on a deconstruction, saying that we need observational studies on the same, let's say, position in the hierarchy as experimental studies, in order to use studies to find out about the effectiveness in certain circumstances. Not just to say, well, we're in another country and it's like this, and so we adopt somehow. I think we need studies at that point, and then we can say we make a recommendation on the basis of observational and experimental studies. So we find then the highest grade of evidence if we combine both, and even qualitative research in one, not in one hierarchy, but in three sides or three dimensions of a hierarchy. Thank you.
Okay, thank you very much. Would like to comment on that? I think your suggestion is to really look good at the levels of evidence and the hierarchy of evidence, and to make sure that you value the different types of research that's being done.
Maybe one additional remark. We just published a model in the American Journal of Occupational Therapy in April of this year for anyone who is interested how we are working on that.
Okay, thank you very much. I'd like to go to this microphone, then that, and then back here up to the front.
Thank you very much. Lorraine D'Souza, Brunel University. I have just a couple of points to make and to offer. The first is about, I have fully appreciate the use of best evidence, but I would put as a strapline to that best appropriate evidence. And I think in the judgment sets that are going to take place, looking at the appropriateness of the evidence within the published articles and research papers is quite important. I will fully support the inclusion of the service users, which are not just our patients, they're very important, but there are a range of service users, the most important being the informal carers of those patients, particularly those with long-term conditions. And when looking at the the last one on the slide up there about considered judgments, that their input into those considered judgments are absolutely fundamental. In my view, the guidelines, when they come out, and I hope that they will, I will fully support this process, they're then published in the public domain, and people like myself and others in the room will then want to do research on those to see if they do actually hack it at the reality of clinical practice. So what I'd also like to see the guidelines generate are a set of research questions where the guideline developers acknowledge that the evidence base is patchy and incomplete. And for our profession of physiotherapy, that's likely to be the case for quite a number of the issues the guidelines might want to present. That also then flags up for everybody, this is not the definitive word. We are pointing the direction for future research in the future development of the guidelines. Thank you.
Thank you. Thank you very much. So the suggestion is make sure that you include the right stakeholders in your development, because there may be many different types of stakeholders. So that's very good. Right. That microphone up there.
Yes, I'm Phil Tygell from the United States. I have 3 questions for you, and I applaud the work you're doing. I think it's fantastic. First, though, I think your next slide, you had the list of evidence you were going to use, and I note that you left out the basic sciences, basic science information, which in the hierarchy of evidence is sometimes the best evidence available. So my first question is, why did you leave out basic science information? Some people might call that soft evidence, but it fits in there. The second question is, as we know, many times for our interventions, randomized controlled trials end up with the conclusion that there is no evidence to prove efficacy. At the same time, they find no evidence that it does not prove efficacy. It tells us more about the randomized controlled trial than it does about the intervention. What do you intend to do with those interventions that seem to work but have not been able to be proven in randomized controlled trials? And the third question, in the United States, we had AHCPR guidelines on low back pain came out about 10 years ago, and they were highly lauded and they were wonderful. But anybody who followed them managed to do nothing to prevent chronicity in low back pain. The low back pain guidelines were not very good. Would you consider subjecting your clinical guidelines to randomized controlled trials before you publish them?
Okay, so there are 3 questions mainly based or related to what evidence could we use, can we use, and how does that end up in the guideline itself. Do we have any thoughts on that? Chris?
So, Phil, I think I'll tackle the first question, which was basic science. It's really hard to take. I mean, believe me, I'm a big fan of mechanistic studies and basic science work, because I think that provides the foundation by which we can start to develop viable clinical interventions, basically. Unfortunately, I don't know where that fits into this process in terms of creating a guideline. But you're absolutely right. We make the assumption that, okay, we know all the interventions right now. We have everything here. We just have to kind of put everything together, match the right intervention in the right scenario. There may be interventions we haven't even developed yet, that we haven't even considered. And that's where the mechanistic and the basic science work really comes into play. We can never forget that. I'm a very strong advocate of that. Now, how that fits into a discrete guideline, I'm not sure about that. But I think as we go forward in our physical therapy research agenda, that we always have to have a good eye on the mechanistic studies and our more basic science studies, because that's how we're going to evolve into better interventions and better outcomes for our patients.
Thank you. Anne?
Yes, I could probably go on for about half an hour with this one. But I completely agree with you. And I think we have to remember, and that's not to say that, if we go along this process, that we're going to stick with the existing model. I think we have to have some discussions about that. This model that we all utilise has come from the pharmaceutical industry, really, and the medical fraternity, and it's about clinical practice. But as physiotherapists, we all know that a lot of the modalities that we actually use have not been tested out fully before they've been utilised, and we're still finding out quite a lot about them from laboratory-based experiments, but also from qualitative elements. And so my challenge is, should we actually, as a first runner, actually be looking at our hierarchy of evidence and incorporate laboratory-based work, basic sciences, and also more qualitative research into our model. And I'm spending a lot of time doing that myself at the moment, thinking about that new model. But it might not be somewhere where the rest of the panel wants to go. But, for me, that is a good move forward.
Right. Thank you.
Oh.
Yes. Support for that?
Yes.
All right, thanks. Very good, very good. This microphone here.
Yes. Hans Lund from Denmark. Thank you for this initiative, and I can fully support your concerns about replication of knowledge and doing the same thing in Holland and America and Denmark and so forth. But some of the other one who had asked the question said we should stick to the evidence and not include all the other stuff in the guidelines. And then I would ask, what is the difference between your initiative and the Cochrane collaboration? If we, on the other hand, say that the strong things about your idea is including different stakeholders, including the experience, including the mechanistic studies, then I think it's a very promising idea to do so. But then you have another challenge, and that is this is very complex. And it is really, I think, so different from country to country, even from part of a country to another part of a country, how they deal with that kind of problems. So I'm simply worrying a little bit about if it is possible. But I can understand your idea, but I'm a little concerned about the possibility of it. Thank you.
All right. Chris?
Well, I'm not sure we know exactly what the problems are until we put our necks out there and actually see what's going on. I mean, why not develop a guideline or a couple guidelines, put them out there for comment and get comments from 100 different countries and 100 different patient organizations within those countries. I think at that point we will know exactly what the barriers are. I mean, we can talk about it all day, but until we actually do something about it and explore those barriers, figure out, okay, what are the major problems? Maybe this is a dream that will never happen. But until we actually go out there and put a foot forward, why not? What do we have to lose? I guess that's the question. What do we have to lose?
Thank you.
And just to pick up on that, I mean, I think we might have a staged development. And maybe one of our first stages is to actually try to implement a research priority exercise in different areas of the world. We just carried out a research priority exercise in the UK that took about 8 months. And actually, it's incredible how the research priorities have moved on in the last 7 years, which is the last time we did one. And we realised that now we need to do it more frequently. But if we could do some kind of priority exercise within the different regions of WCPT, that might actually be helpful in understanding perhaps which of the guidelines we want to look at first.
Okay, thank you. That microphone? No, there's somebody there. I haven't seen that. Yeah, you're up. Yeah. Yeah.
Hello. My name is Xin Yi. I'm from Singapore. I was just wondering, because all what we're doing about evidence-based guidelines is actually to improve patient-centered care and the quality of life. So ultimately, we want to encourage evidence-based practice in different parts of the world. And because I was just wondering that some countries would have their own national guidelines, but there are other countries who do not have their national guidelines. So if you look at it at another angle, would it be idea to actually have a panel of experts who go down to the country to help them develop their own national guidelines instead of coming together to form an international clinical guideline, because the applicability in each country would be pretty difficult. Yeah.
Okay, thank you. So your suggestion is, could we create a mechanism to help?
The other countries. Yes, because they do not have the capacity or the resources to develop, or may not know how to go about doing their own national guideline, which could be much more important to their own population rather than having an international guideline.
Okay, thank you. Yeah, thank you. I'd like to go to that microphone, then front, then back to that microphone again, and then I would like to sort of come to a conclusion of today. So.
Neil O'Connell from Brunel University again. I've heard from a few people now a criticism of the existing hierarchy of evidence and the validity of RCTs. I think we need to be a little bit careful here that we don't think that because RCT didn't tell us at times the message we wanted to hear, it means that the RCT must be wrong or in some way insensitive. Maybe there was nothing to find. And, you know, when we do decide to change a hierarchy of evidence that is reasonably widely accepted across any number of disciplines, again, we should be mindful of the message that sends out to other disciplines as well, because we would be in danger of invoking what I would call the homeopath's defence in that case. And I don't think, as a physiotherapist, I would be comfortable going down that road, because it's a road to self-justification and not evidence-led practice, in my view.
Okay, thank you. That's very clear.
Tracy Berry, WCPT. I thought I'd come and speak because WCPT has been mentioned a few times, and both financial and moral support was mentioned by Philip at the beginning. And certainly I have to come here with empty pockets. WCPT doesn't have spare cash in a back pocket or a corner stashed away, but what we do have is invaluable networks and connections around the world. And I thought I'd just highlight those in the assumption that this goes forward, which I think sometimes you have to look at things as a pilot study. And this may well be you have to, as you say, stick your necks out, give one a go, and see what feedback you have. We have a database of experts in practice, education and research. That's a way of tapping into expertise around the world. We have a website, which could be an open access publishing platform, and that picks up on the issues around dissemination. We can't tackle the implementation aspect, but we can open up communication channels. We have 106 member organisations. We have contacts in all of those. So if it's finding people and it's getting information out, those are areas that we can help with. So it's very much promotional and support and moral rather than financial that we could offer. But it's there, and I think it's a way of connecting us all globally. Thank you.
Thank you very much. I think it's very valuable. Thank you for your support. The last one.
Hello, Kathy Sherrington from Australia. I'd just like to support the initiative and just, I guess, ask a practical question about how people kind of become involved in this. I guess personally I'm interested in the area of physiotherapy for older people. So, yeah, I guess just a practical question about moving on and how we can actually contribute.
Okay, thank you. Well, that's maybe a good bridge to coming to my conclusion, because before I would like to do that, I know that some of you have left. So there may be a biased sense of what the feeling of the room is right now. But just by a show of hands, who does support this initiative and think we should go on with this? Could you show your hands? All right. That seems a majority. Okay. That's good to start with. Who of you would like to be involved in any way, being either in a working group or in a reference group or in another way of trying to help us to develop these statements? Who of you would be that? A little bit less. All right. But still, quite a few. And then, those of you who said, okay, I would like to be able to contribute to that, whom of you would do that from a clinical, a practical perspective? And then the second question would then be, who would that do from a scientific perspective? But first to the clinical perspective, who of you are the clinicians that would like to be helping us in that? A couple. And scientists doing the research, a bit more. All right, but still, we've got quite a show of hands here. All right, so that gives us a bit of a perspective. Now, before I come to the end conclusion, I just would like I didn't prepare them for that, but go through my panel, see what your thoughts are on having heard this discussion for the last hour, and which way you think your first ideas are for proceeding. So I'll start in the back with Rob.
I agree with Chris. I think it needs to be given a go. I think from the excellent discussion that's preceded this, I think it will be a struggle to get buy-in from all of the international physiotherapy profession. But perhaps if we can produce good quality guidelines, a good quality guideline for which there's a large degree of support, that would be a very good outcome.
Aimee?
I agree wholeheartedly. If we hadn't ever given things a go, from where I come from, we would never have done anything. So I think that we need to stick our necks out. I think we need to make a start. And once we've made a start, then we will get better and better at the job. So I would support the initiative.
Thank you. Chris?
I think all of us, as part of this group, knew this was going to be a very challenging effort. This is not easy. And we're not fooling ourselves by being up here saying, oh, yeah, this will be a slam dunk. This is going to be a very difficult process. But everything that's difficult starts somewhere. And I think if we looked ahead 20 years for where this profession needs to be, where 100 countries are on the same level from an educational standpoint, research standpoint, and most importantly, clinical practice standpoint, I think we have to look ahead to where we really want to be in 20, 30 years. And I think maybe we'll look back at this date today and say, this was well worth it. But I think we should at least try it and be very selective of where we start, how we start it, pick the least controversial area where our strongest evidence is, where we think we have greatest applicability and impact on the world, and go from there.
Thank you. Anne?
Yeah, I'd fully support that. I just want to come back on a comment that was made earlier about RCTs, if I may. And I am fully supportive of RCTs if they answer the right question. I just think there are lots of other ways that we can approach research which answer different questions that we might need in order to underpin future RCTs. So that's where I'm coming from with that. But I fully support this initiative. And as Chris has said, it's going to take us a long time probably to get there. But I think we're starting those discussions now, and I think it's been really useful.
Thank you very much. All right. Then I think I'll take my chances and say, well, by now this initiative is officially launched. So I think we should go on with this. So thank you for that. Thank you for your support. I think the next step would be that we as an initial steering group would try to sort of wrap up what's being said today, what that would bring us for developing these statements. I'd like to invite you, if you come up forward once we are done here, if you say, oh, I'd like to be involved in the initial steering group activities, please identify yourself. But what we also will probably do is use the infrastructure of WCPT, as Tracy Burridge mentioned, to communicate on what's going on. And then from that point on, we can also see on what other ways you might be involved, and whether it would be in working groups or reference groups or identifying the priorities. So there are many activities for which we can use the infrastructure of WCPT. So thank you, Tracy, for providing that. So thank you all very much. I think we've got work to do, but now first lunch. Thank you.